10 months following the initiation of the treatment, the patient comes to the clinic feeling nauseous, fatigued, symptoms suggestive of progressive disease. Scans get checked. The patient has progressive disease. So the discussion ensues, and the decision is to shift her to second-line therapy. Although the part of the discussion also included perhaps reconsidering oxaliplatin, but because of some residual neuropathy, we decided to proceed with FOLFIRI plus cetuximab. Since this was a left-sided tumor, we didn't want to wait too long for the line of therapies before starting the EGFR inhibitor. The patient went on FOLFIRI cetuximab, had some stable disease, and then at 4 months started showing evidence of symptoms that suggested progression again, which were confirmed by the scans. A patient that failed on FOLFOX bevacizumab and going through the first line, and then went on capecitabine bevacizumab as a maintenance strategy. The discussion about what to do next includes 2 options. 1, switch complete therapy. 2, reinitiate oxaliplatin. Reinitiation of oxaliplatin is based on what we know from the OPTIMOX study, a little bit from the Cairo study, is we can get a small percent of patients to respond, 20%. So it's not a major benefit, but it's also important not to waste an additional line of therapy. This is usually limited by neuropathy for many patients, and the natural choice would be to proceed with FOLFIRI. We have 2 options. The option of continuing with bevacizumab, so bevacizumab beyond progression, or the option of switching the biologic to cetuximab or panitumumab. And given that the patient has a left-sided tumor, which is RAS wild type, and we know that EGFR inhibitors do benefit those patients in earlier lines of therapy, perhaps with a much greater effect than, say, bevacizumab, and especially in the second line where bevacizumab does not seem to add as much activity, the decision is taken to proceed with an EGFR inhibitor with cetuximab at this stage. Thus, the choice of FOLFIRI cetuximab. 4 months following treatment with FOLFIRI plus cetuximab, the patient experienced significant fatigue. So the question is, what do we do at this point of time? The difficulty with chemotherapy plus an EGFR inhibitor is we do not have much data on maintenance strategies, unlike with chemotherapy plus bevacizumab followed by capecitabine plus bevacizumab. So in this case, the chemotherapy is the primary contributor for the fatigue. We think the decision was to drop FOLFIRI and to continue with single agent cetuximab as a maintenance strategy, understanding that cetuximab is both relatively cytotoxic and cytostatic, and so it can serve as its own maintenance strategy.